Welcome all. I'm Mohammed Zohdy. I'm lecturer of surgical oncology in the Oncology Center, Mansoura University. And in this lecture, we are going to discuss nutrition in cancer and the cancer surgery. So regarding the definition, malnutrition in cancer patient is an acute, subacute, or even a chronic stage of nutrition in which there is a combination of variable degrees of over or under nutrition with or without inflammatory activity that has led to a change in the body composition and diminished function. This state is characterized by weight loss, hypoalbuminemia due to decreased skeletal muscle mass, and reduced fat storage. So how can this malnutrition affect the cancer patient? First of all, it leads to increased morbidity, leading to higher rate of toxicity during receiving the treatment, either chemotherapy or radiotherapy, increased the patient's hospital stay, length of hospital stay, and treatment costs as well. Also, decreased performance status and the quality of life, prolonged recovery, poor wound healing, and the development of infectious complications. Of course, this will lead to negative impact on survival. It's also important to mention that loss of more than 20% of body protein has a negative impact on respiratory muscle structure and function and affection of cell-mediated immunity. Malnutrition is observed in about 40% of cancer patients. Patients with certain cancers, such as cancers in the head and the neck, stomach, and bowel, may be malnourished at diagnosis. Therefore, nutrition intervention is often warranted for these individuals prior to surgery. Nutrition-related side effects also may occur as a result of surgery, as surgical resection or excision may result in adverse effects on the gastrointestinal function depending on the tumor's extent and also the extent of surgical resection. We should also say that potentially beneficial cancer treatment may result in caloric depletion. So cancer-associated nutrition depletion is a syndrome. We call it cancer-associated cachexia syndrome or cancer cachexia syndrome. This syndrome is characterized by different symptoms, starting from anorexia, reduced food intake, wasting of the patient, fatigue and reduced daily activity, and impaired immune function. The prominent clinical feature of cachexia is weight loss in adult. The degree of cachexia is classified into either moderate, which means loss of less than 5% of the body weight, moderate, which means loss of 5 to 10% of the body weight, and severe, which means loss of more than 10% of body weight. The highest incidence of and severity of cachexia, cancer cachexia syndrome, is seen in pancreatic and gastric cancer patients, wherein approximately 85% of these patients experience cachexia. Moreover, severe malnutrition can be also observed in upper GI and pancreatic cancer, while less severe malnutrition will be observed in patients who suffer from lymphomas, breast cancers, and sarcomas. This cancer cachexia syndrome is an independent predictor of shorter survival, leading to increased risk of treatment failure and toxicity, and it reduces also the quality of life of the patient and may be responsible for nearly 20% of all cancer-related deaths. In this table, we can find that cancer cachexia syndrome affects the general cancer population in about 60 to 63%. If we sort them by the type or the type of cancer, we will find that esophageal and gastric carcinoma are the most common to develop patients are the most common. Esophageal and gastric cancer patients are the most common to develop cancer cachexia in 83 and 79%, while head and neck cancer patients experience malnutrition in about 72, or cancer cachexia syndrome in about 72%. So how this cancer cachexia syndrome develop? Its mechanism is mainly based on pro-inflammatory cytokines like tumor necrosis factor, interferon gamma, interleukins 1 and 6, hormones and neuropeptides like leptin, neuropeptide Y, and ghrelin. Tumor necrosis factor plays an important role in the body's response to a variety of immunologic and inflammatory changes. It's responsible for the local host defense mechanism during either injury or infection or inflammation. These metabolic changes will lead to cachexia such as lipolysis, muscle catabolism, and increased glucose turnover and utilization. Moreover, tumor necrosis factor enhances lipolysis. The next pro-inflammatory cytokine will be interferon gamma and interleukins 1 and 6. Interferon gamma is similar to the tumor necrosis factor in that it potentiates and initiates lipolysis, inhibiting lipoprotein lipase and decrease the protein synthesis. Interleukin 1 acts centrally to induce anorexia by causing early satiety, increase proteolysis peripherally, and stimulates the production of interleukin 6. Regarding leptin and neuropeptide Y, these hormones have recently been identified, or neuropeptides have recently been identified to affect or to lead to cancer cachexia. Leptin via the hypothalamic neuropeptides regulates the adipose tissue mass, it reduces the appetite and increases the resting energy expenditure and regulates the insulin levels. So, how can we assess the patients or the cancer patients to determine if they have malnutrition or cancer cachexia syndrome or they don't have? First of all, the most basic is to ask the patient about weight loss, and this is still the simple and the best valid method for assessing the nutritional status in cancer patients. We have two main tools to assess the nutritional status: nutritional assessment and nutritional screening. Both of these methods or tools should be mandatory and regular part of the medical care of cancer patients. The main difference between them is that nutritional screening is more simple, rapid, and easily performed, so it's used at the beginning just to determine if this patient suffers from malnutrition or not, while nutritional assessment is a more detailed evaluation. What are the nutritional screening tools do we have? We have many tools we will discuss in the upcoming slides, like subjective global assessment, patient-generated subjective global assessment, nutritional risk screening, malnutrition universal screening tool, malnutrition screening tool, and mini nutritional assessment. While nutritional assessment is done through measurement of the nutrient balance regarding the nutritional intake and output, measurement of body composition like by using BMI, body mass index, anthropometry, and bioimpedance analysis, measurement of the inflammatory activity by measuring laboratory investigations like C-reactive protein and total leukocytic count, measurement of function of the muscle or the respiratory function, and even the immune function. These measurements should be repeated at various time intervals according to the clinical status and the patient's needs. So we'll start to discuss the nutritional assessment tools. The nutritional screening tools, sorry. The first tool of them is the subjective global assessment. This tool is based on, first of all, some patient's history items like weight loss, a change in the dietary intake, GI symptoms, and functional capacity. Also, we will perform a physical examination of the patient to assess his muscles, subcutaneous fats, edema, and presence or absence of ascites. And then we will have an overall subjective judgment for this patient to determine whatever he is in a good nutritional status. The patient will be classified as category A, or in a moderate malnutrition status to be classified as category B, and in severe malnutrition status to be classified as category C. The second tool for nutritional screening is patient-generated subjective global assessment, and in this tool it will be based on patient portion and the clinician component. The patient portion is the weight loss in the past months and the past 6 months, his current oral intake compared to the baseline, and his current physical activity compared to the baseline. While in the clinician component, we will assess disease and related metabolic demands of the patients, his cancer status, his wound status, if there is any age, if his age is more than 65, if he has any associated HIV infection, pulmonary or cardiac cachexia. We will also assess his metabolic demands. We will assess also fever or sepsis or steroids. And of course, we will perform physical assessment and examination. The next tool for nutritional screening is the nutritional risk screening. It will assess 4 items. If the BMI is less than 20.5, if there is body weight loss during the last 3 months, if there is low dietary intake during the last week, and the disease severity. And in this tool, if we find our patients who scored more than 3, more than or equal 3, are classified to be at nutritional risk for malnutrition. The next tool will be the famous malnutrition universal screening tool. This tool assesses the BMI score if there is unplanned weight loss during the last 3 to 6 months, if there is acute disease affect score, or no nutritional intake for more than 5 days. This must tool will assess the following items. First of all, BMI. If the patient's BMI is more than 20, this patient will score 0. If the BMI is from 18.5 to 20, the score of the patient will be 1. We will give him a score of 1. If it's less than 18.5, we will give him a score of 2. And then we will assess the weight loss in the 3 to 6 months. If this weight loss is less than 5% of his baseline body weight, the patient will be given a score of 0. If the weight loss is from 5 to 10%, the patient will be given a score of 1. And if the patient is lost more than 10% of his baseline body weight, the patient will be scored 2. And then we will assess the acute disease effect and add a score of 2 if there is history of decreased intake for more than 5 days. If the patient's overall score is 0, this patient needs routine clinical care. 1, this patient will need observation, while 2 or more, the patient will need treatment. The next tool will be the malnutrition screening tool, and this tool is based on 2 main questions regarding if there is recent unintentional weight loss, low food intake because of decreased appetite. This tool provides a score between 0 and 5 with a score of more than 2, indicating that there is a risk of undernutrition. The next tool will be the mini nutritional assessment, and this tool is similar to the malnutrition universal screening tool with additional questions on the neuropsychological functional status, the physical mobility of the patient, and food intake. The scoring here is opposite to the scoring in the malnutrition universal screening tool, with the lower score denoting that this patient has higher risk of malnutrition. What are the other tools do we have for nutritional assessment or screening? We have, of course, the famous clinical assessment to assess the weight loss of the patient. If it's more than 10%, this means that there is malnutrition and this patient mainly needs the treatment. The BMI or the body mass index we'll discuss in the next slide. We have also anthropometric measurements like measuring the triceps skin fold. If it's more than, if it's less than half an inch, there may be malnutrition. Mid-arm circumference, also hand grip strength, and we have also the blood indices or the laboratory investigations like the serum albumin, the total leukocytic count, the pre-albumin, the transferrin, or the creatinine excretion. This is the BMI, the body mass index, how it's calculated by dividing the weight in kilogram over the height by meter square, and we will classify according to the result. If it is less than from 20 to 25, this is normal. Less than 20, this is called malnutrition or undernutrition. We have overweight from 25 to 29.9, and we have obese patient. And we have obese patient 30 to 39.9, and we have morbid obese patients more than 40. Although BMI is an internationally accepted tool for assessment of the nutritional status, but it has some limitations. The first of all is that it does not assess the body composition, and also it does not provide accurate information about the weight alterations related to an increase in the lean body mass or body fat. It also does not consider any gender or ethnicity changes or variations. Sorry, it has low sensitivity to detect individuals with increased body fat. So now we have a cancer patient who suffers from malnutrition or cancer cachexia syndrome. What are the indications that we should provide him with nutritional support? There are some clinical indications. The first of them is the preoperative nutritional depletion. The patient have an advanced esophageal cancer or an advanced gastric cancer that leads to decrease the oral intake, and so the patient had cachexia. So this is preoperative nutritional depletion to prepare him for surgery. We have also the development of postoperative complications like paralytic ileus for more than 4 days. This will need nutritional support. We have also development of infection and sepsis that will need nutritional support to maintain or to go with his hypercatabolic state. And we have also the development of fistula or leakage from an intestinal anastomosis that may need a stoppage of oral intake and maintaining the nutritional support. We have also massive bowel resection or even in management of radiation enteritis, which is a famous complication of radiation therapy due to irritation or affection of the small intestine. How can we, what is the approach or how can we provide these patients with the feeding? We have two types. We have enteral feeding and we have also parenteral feeding. Regarding the enteral feeding, first of all, we can start enteral feeding by mouth. And of course, as this is the natural way, it should always be attempted. We should always try to provide enteral feeding to the patient through the mouth. If it is inaccessible or ineffective, we could consider the next one, which is the enteral feeding but through a tube. This tube can be either nasogastric tube, which is RILE as you all know, okay, or maybe endoscopically guided nasogastric tube insertion if there is an esophageal stricture or locally advanced esophageal cancer, so I cannot insert this RILE. And we have also nasogastroduodenal or jejunal tube. In this maneuver, we introduce the nasogastric tube not only to the esophagus and the stomach, no. Through endoscopic guidance, we can go make the tube go down to the jejunum. The third approach in enteral feeding will be enterogastrostomy. In this approach, it's an operative placement of a tube or catheter in the gastrointestinal tract. What's the indications? Indications is that if we cannot introduce or pass a RILE, or if the nutrition is expected to be for a period of more than 4 weeks. While the contraindications include complete or partial gastric or intestinal obstruction. This tube, or the gastrostomy tube, could be inserted or could be performed as a surgical procedure alone, or can be performed as an adjunct to surgical another surgery, like what we do in esophagogastric resection. We can do the resection and also insert a jejunostomy tube to maintain the nutritional status of the patient till the anastomosis, the intestinal anastomosis heal, and also his wound is better. Okay, the choice of this procedure is to fashion are either a choice. We have two choices: either to perform a gastrostomy or perform a jejunostomy. In the first one, we insert the tube in the stomach and the feeding is through the stomach and the small intestine. While in the second one, we are excluding the stomach, so there may be a problem in the stomach like gastric cancer or something, so that I cannot introduce a tube in it. Types of this gastrostomy: we have a stem gastrostomy, which is a temporary procedure. We have a Janeway gastrostomy, which is a permanent tube feeding, and we have the Witzel gastrostomy, which is more famous in jejunostomy through making or performing a serosal tunnel for the tube for long-term feeding. And of course, all these are performed by surgery through upper midline incision. Removal of this tube will lead to rapid shrinkage of the cutaneous orifice and the trachea. Performed to preserve the established gastrostomy tube. To preserve the established gastrostomy, this tube should be reinserted again, and a caution should be taken that this tube is in situ before feeding is recommended, or recommenced. Sorry, feeding is performed again. This is a famous gastrostomy tube. It's called Dipizar tube. As you can see, its end is like an umbrella so that it can be lodged in the stomach and prevent its dislodgement through the stomach and failure of the procedure. And of course, it has different calibers, as you can see also in the photo, depending on the patient's build, depending on the patient's stomach, and also the amount of feeding I'm going to introduce for this patient. This is the operative technique for stem gastrostomy in picture A. Okay, we just perform a puncture in the anterior gastric wall and insert the tube. We perform a two-pierce string, and then we fix the anterior gastric wall to the abdominal wall, and then introduce the or get the tube out of the skin for feeding. We have also the Wetzel technique for gynostomy or for gastrostomy, in which we perform a serosal tunnel for this tube to ensure long-term feeding. The next approach for performing a gastrostomy will be percutaneous endoscopic gastrostomy, PEG. This is the abbreviation, percutaneous endoscopic gastrostomy, in which we perform insertion of the gastrostomy through endoscopic guidance. We perform upper or esophagogastroduodenoscopy and then go down to the stomach, and we will have the light of the endoscope evident through the skin, and then we will insert the special kit. It will not be the regular gastrostomy tube you saw or the Dipizar tube. No, it will be a special kit to be inserted through the skin. Of course, it's contraindicated if there is complete esophageal obstruction because the scope will not pass. Also, it's contraindicated if there is ascites or sepsis, or if the patient has abnormal clotting or abnormal bleeding profile, and also in patients who perform peritoneal dialysis. The second tube is gynostomy tube. We can perform it either through Wetzel gynostomy by performing a serosal tunnel so that we can use it for long-term feeding, or needle gynostomy using a special kit and a catheter. The ease of gynostomy as an adjunct to an intra-abdominal surgical procedure has increased in popularity. Gynostomy is a procedure of choice because it's easily inserted, and also the initiation of early post-operative feeding and the avoidance of risk of pulmonary aspiration. So by this we finished the enteral nutrition. Regarding the parenteral nutrition, it means that we provide the patient with all his nutritional requirements, but through IV, through intravenous route, without the use of GIT. Why? Because the GIT may be blocked due to stricture or neoplasm. There may be the GIT is short due to massive intestinal resection in advanced ovarian cancer or something else. This is called short bowel syndrome. Or there is leakage from intestinal anastomosis, which we call fistula or enterocutaneous fistula, or it may be markedly inflamed inflammatory bowel disease like Crohn's and ulcerative colitis, or the patient's GIT cannot cope due to severe trauma the patient had or hypercatabolic state. How can we deliver the intravenous nutrition? Either through a central route, and this is the better. Okay, this catheter is a catheter, central venous catheter, is inserted either in the subclavian or the internal or external jugular vein. And we have also the peripheral IV line for short-term feeding. The type of parenteral nutrition we deliver is called total parenteral nutrition. As I told you in the previous slide, we provide the patient with all the nutritional requirements he needs. So we will give the patient all the nutritional requirements. We will give him protein in the form of amino acid. We will give him fat in the form of fatty acid, and we give him also carbohydrate in the form of glucose by higher concentration, maybe 25%. Also, we give him water soluble, we give him fat soluble vitamins, and we give him some minerals like calcium and phosphorus and so on. How can we monitor this patient? This patient needs strict monitoring. Daily, we can measure his weight. If it's difficult, of course, we will depend on the fluid chart to measure the patient, the input through the IV fluids he took, and the output through urine, and also vomiting if there is vomiting, and the insensible water loss through sweating, especially in the hot weather, and also full blood count, blood glucose. Twice weekly, we can ask for calcium, serum calcium analysis, phosphorus, serum albumin, and renal function test. And weekly, we'll assess his liver function tests and serum folic acid or folate and serum vitamin B. Complications. This total parenteral nutrition has several complications. First of all, it can lead to some nutritional deficiency if there is deficiency in some minerals in the fluids or in the solutions I give him. Also, patient may suffer from hyperglycemia or hypercholesterolemia. Patient may suffer from metabolic abnormalities like metabolic acidosis. And we have the most common complication, which is catheter-related complications, either sepsis due to infection, okay, or malposition, or even during its insertion. Injury to the pleura may occur and may lead to pneumothorax. Patient may have air embolism if some air embolus comes through the catheter into the central vein. That's why we ask the patient to lie completely flat while we are removing this catheter, and also to hold his breath so as to avoid aspiration of air through the catheter. And also peripheral line thrombophlebitis may develop. That's why we prefer to introduce or to give the patients the total parenteral nutrition through central line, not through a peripheral line. The recent trend we have in surgical oncology is the enhanced recovery after surgery protocol. This enhanced recovery, or the purpose of this enhanced recovery after surgery protocol, is to reduce post-operative stress and improve the clinical practice. How? By incorporating evidence-based medicine in the patient's management. Okay, this protocol or enhanced recovery protocol is implemented through a multidisciplinary team. This team involves surgeons or surgical oncologists, okay, and anesthesiologists and nurses, and maybe also a nutritionist. The patient will need to have optimal pain control, not to suffer from any pain, and the prevention of fluid overload and aggressive post-operative rehabilitation, including early recovery of oral feeding and also early mobilization. The main impact of this is that it improves the short outcomes of surgery. What are the components of the enhanced recovery after surgery protocol? We divide it into preoperative, intraoperative, and postoperative steps. In the preoperative steps, of course, first of all is the pre-admission counseling. Patient should be counseled about his status and all the items of his treatment plan. Okay, patient also will have good fluid and carbohydrate loading, no prolonged fasting, no or even maybe selective bowel preparation. But regarding this point, we have to mention that the bowel preparation is still debatable in cases that will undergo a colonic resection or colorectal resection. The most recent guidelines published by the European Society of Coloproctology in 2017 mentioned or stated that mechanical and chemical, combined mechanical by enemas and chemical by antibiotics preparation of the GIT is better than no preparation at all, because it decreases the incidence of post-operative infection and post-operative leak from the anastomotic sites. The preoperative items also include thromboprophylaxis and no pre-medication. Intraoperatively, the anesthesiologist should ensure short-acting introduction or implementation of short-acting anesthetic agents. Also, the patient should have epidural anesthesia and analgesia during the operation. No drains should be inserted by surgeons, avoidance of salt and water overload, and maintenance of the normothermia or the normal blood pressure. Post-operative, the patient will continue his epidural analgesics, no nasogastric tubes at all. Try to prevent nausea and vomiting as much as possible. Avoid salt and water overload, early removal of urinary catheter, early oral intake, early mobilization. Try to use the non-opioid analgesics as much as possible and non-steroidal anti-inflammatory drugs. If we use the opioid analgesics, it's somehow accused by delaying the intestinal motility, so that's why we shift for the non-opioid analgesics, and also stimulation of gut motility by some prokinetic drugs to avoid paralytic ileus. This enhanced recovery after surgery protocol is very important in that it leads to better surgical outcome and better recovery of the patient, earlier return to his daily activities, and also less or shorter hospital stay, which of course will have a good impact on the health costs spent by the government or spent by the hospital. The last item we are going to finish with is the nutritional support guideline recommendation as recommended by the American Society of Parenteral and Enteral Nutrition. We have 10 recommendations. First of them is that patients with cancer are nutritionally at risk and should undergo nutritional screening to identify those who need formal nutritional assessment and development of a nutritional plan. The next recommendation is that nutritional support therapy should not be used routinely in patients undergoing a major cancer operation. Should not be used routinely. Okay, patients should be screened for malnutrition, and then we should decide whether to perform nutritional support or not. Perioperative nutrition support therapy may be beneficial in moderately or severely malnourished patients if administered for 7 to 14 days preoperatively. However, the potential benefits of this nutritional support must be weighed against the potential risk of the nutritional support therapy itself and delaying the operation. Of course, nutritional support therapy shouldn't be used routinely as an adjunct to chemotherapy. Nutrition support therapy should not be used routinely in patients undergoing head and neck or abdominal and pelvic surgeries and radiation. Nutrition support therapy is appropriate in patients receiving active anti-cancer treatment who have, of course, malnutrition or who are anticipated to be unable to digest or absorb adequate nutrients for prolonged period of time from 7 to 14 days. The palliative use of nutrition support therapy is rarely indicated. Omega-3 fatty acid supplementation may help in stabilizing the weight of the patient on oral diets. Patients shouldn't use a therapeutic diet to treat cancer, and we can use immune-enhancing enteral formulas containing mixtures of arginine and nucleic acids and essential fatty acids, which may be beneficial in malnourished patients undergoing major cancer operation. This is our reference, which you could check for more detailed information. And lastly, thank you. I hope you enjoyed this lecture. I hope you know now better about the importance of preventing malnutrition in cancer patients. And thank you.